physiological function of the tissue is impaired. Ulcer is defined as an interruption of continuity of an epithelial surface with an inflamed base and is usually a result of an underlying or internal etiology. And then wound healing is defined as a complex series of reactions and interactions among cells and mediators in four distinct and overlapping phases. So next is the classification of the wound. Uh, Wound classification does not have a really specific classification. However, there are some however, wound can be classified into different types, which include type. First, can include timing, which can be comprised of acute, chronic, and also non-healing wound. As for acute wound, it is defined as a sudden disruption of skin integrity and is usually due to trauma or surgery. For chronic wound is a wound that failed to proceed through an orderly and timely process to produce anatomic and functional integrity. And then unhealing wound is a wound that has no signs of healing process within 2 to 4 weeks after appropriate intervention. And then wound can also be divided into open and also closed wound. Open wound meaning the wound has a complete break of epithelial surface with underlying tissue damage and can include wounds such as abrasion wound, laceration wound, incision wound, avulsion wound, and also puncture wound. And then closed wound, the skin is intact with underlying tissue damage. Example of closed wound include bruises and also contusion.
Fifa, apa that go to previous slide. Now you describe the wound is actually the next one, the before the other one. See? Okay.
This one
Is
and
injury integument to underlying structures.
eh,
So it's actually break of the
Skin. Epithelial. Jawapan dia.
break after epithelial.
Layer.
hmm?
Break of
Break
the
of the
epithelial.
epithelium.
Uh,
Ha.
Itu jawapan dia.
or to the underlying structures.
Wah ilaha illallah, tengok tab dia. Serupa Akmal tabnya. 15 juta setengah no.
It's
Banyak
break
siut
of the
tab.
integument, isn't it? The wound.
Dah dari tadi lagi. Banyak siut tab.
Yes, bro.
Kita tutup sikit. Dah
Mm.
tulis dalam group.
If you go back and check again, because wound, what I remember is actually the loss of the continuity of the skin. So that's how apa ni apa, it's not a skin only lah. Mucosa, so it's considered wound. It's actually cannot remember which already. Yalah, the an injury to the integumentary to the underlying structure, betul lah. Injury is actually a very broad term.
Yeah. Injury is anything.
So
Main bola injury.
Discontinuity.
Bancap terlebih injury.
uh, you go back and check
Tak
again
boleh
Okay.
what it means by injury in the wound.
Okay.
Okay, go back to the this one, the open close wound just now.
boleh ada injury di mana-mana.
Right. So when there is an intact skin, then you cannot call that a wound. If you follow the descriptions of the break of or the integuments of the structure. So that's why the open and closed wound is actually this another discussions. That's why bruises, contusion not considered as wound.
Okay.
In certain discussion lah. No, I'm not saying that you are wrong, but you have to explain a bit further on that because this is actually based on the certain discussions, not simply open and closed wound. Okay.
Okay. Thank you, bro. Okay. And then wounds can also be classified into its etiology, which include traumatic wound, and then various type of ulcer, which example pressure ulcer, vasculitic ulcer, diabetic foot, neuropathic, venous ulcer, arterial ulcer, and also malignant ulcer. And wound can also include burns and also surgical wound. Okay, and then
Ni ulceration.
the traumatic wound can be further divided into the wounds that are caused by blunt force trauma or wounds that are caused by sharp objects. So the wounds that are caused by blunt force trauma include abrasion wound, or can be called as bruise or scratches, which penetrate the epidermis and epidermis layer, and it's usually caused by tangential impact. And abrasion wound has different types, which include brush abrasion, crushing, fingernail pattern, or postmortem abrasion. And then confusion of bruises, which defined as extravascular collection of blood underneath an intact epidermis, as you can see in the picture here. So in this kind of wound, there is damage to vein, venules, and also small arteries. And to differentiate between bruise and contusion, the bruise, the wound, the lesion will be visible through the skin. However, the contusion, it is usually cause an internal organ damage. And then laceration wound, which is a penetration of full thickness of the skin. And compared to the incision wound, it has unclean cut and is usually caused by blunt object. Okay, next is the wound that is caused by sharp object, which is the incision wound, which is an injury that can be caused by sharp instruments such as um, knife and etc. Example of incision are cuts which is longer than depth and involve full thickness of skin and usually spare the underlying organs. On the other hand, the stab wounds or penetrating injuries, it is deeper than the length and usually involve full thickness of the skin and also involve the underlying organ. Okay. Okay, next we go to the phases of the wound healing, which can be divided into 4 phases, which include hemostasis, inflammation, proliferation, and maturation. Okay. As for the hemostasis, it is the process of the wound being closed by the clotting process. So it usually starts when the blood leaks out of the body, and the blood vessel will constrict to restrict the blood flow. And then after that, the platelet will stick together, which is called the platelet aggregation, in order to seal the break in the wall of the blood vessel. And then finally, the coagulation cascade will be activated, the coagulation will occur and then will reinforce the platelet plug with threads of fibrin. Okay. So and then the outcome of the hemostasis process is the formation of a thrombus or fibrin clot, which will keep the platelet and also blood cells trapped in the wound area. Okay, next is the inflammation process, which is the second stage of wound healing, and begin when the injured blood vessel start to leak transudate, which made of water, salt, and protein, and then will cause localized swelling. As for inflammation, it is function in both controlling the bleeding and
Afifah,
also prevent the infection. Yes, Prof.
hello.
Hello.
Now, when you are talking about phases wound healing, phases is not inflammation. Inflammation is a process. So the phases is inflammatory phases, proliferative phases, and maturation
Inflammation
phases.
phases.
So inflammation is a process.
Okay.
Mm.
Inflammatory phase. Okay, and then in the inflammatory phase, then the damaged cells, pathogens, and bacteria will start to be removed from the wound area by the action of the phagocytosis by the neutrophils and also monocytes. And then for the outcome, it will form a healthy wound bed by the formation by the action of the neutrophil and also monocytes. Okay, next is the proliferative phase, which is the phase where the wound will start to contract as new tissues are built. And then in addition, a new network of blood vessels will be constructed so that the granulation tissue can be healthy and also can receive sufficient oxygen and also nutrients. And then at the same time, the myofibroblasts will cause the wound to contract. And then contract by gripping the wound edges and also pulling them together. And then as a result, the epithelial And then in the final phase of the proliferative phase, the epithelial cells will resurface to the injury surface, and then the epithelialization will start to occur. Okay, and then lastly is the maturation phase, which is also called as the remodeling stage. Is when the collagen will be remodeled from type 3 to type 1, and the wound will start to fully close. And then the cells that had been used to repair the wound, which are no longer needed, are removed by apoptosis process.
Dia macam
And then during
body
this
macam
phase
dia
2,
macam
collagen
tadi
is
tu.
aligned along the tension lines, and the water will be reabsorbed so that the collagen fibers can lie together and form a cross link, and then form an increased tissue strength. Okay, lead to an increased tissue strength. Yeah, so this is the summary of the phases of wound healing, where we can see the process is overlapping, quite overlapping with each other. Okay, and then we move to the types of wound healing, which can include primary intention, secondary intention, and also tertiary intention. As for healing of primary intention, it usually occur in wound with dermal edges that are close together, as you can see in the picture here. And then it is usually faster. Its healing is usually faster than compared to the secondary intention. Okay. So for example of wound that are meant to heal through primary intention include simple, clean, or non-contaminated wound with minimal tissue loss and surgical incision. Okay, next is the secondary intention wound, which is the wound that is intentionally left to heal on its own. And it can also include a planned cosmetic closure after healing has progressed to an desired or anticipated point. And then in this secondary intention type of wound healing, the traumatic wound will usually will be left open to heal, to remove bacteria, to allow removal of bacteria, and also to allow removal of the contamination of the wound. And then the wound will be closed after few days or weeks. And then so this delay will usually allow time for improved edema or infection uh, of the wound. And then third kind of wound closure and healing is tertiary intention, which is also called a delayed primary intention, when the wound is initially left open after debridement. And then after a period of open observation, then after the wound appear clean, and also there is evidence of good tissue viability and also tissue perfusion, then there will be subsequent surgical repair of the wound. Okay. So for secondary intention wound, types of wound that are allowed to heal in secondary intention pathway is, for example, wound with skin infarction, ulceration, abscess cavity, puncture wound, and then wound that has that affect the partial thickness of the skin, which include abrasion wound, second degree wound. And then as for tertiary intention wound, example of the wound that are allowed to heal in tertiary intention pathway is example bite injuries, infected injuries without any significant tissue loss until the infection is controlled, and also laceration wound which involve foreign body. Okay. The next is the wound assessment. When patient come with a wound, then we have to do wound assessment, which include general and also local wound assessment. So general assessment is to identify and eliminate any underlying causes or contributing factors which may impede the wound healing process. For example, if patient is in extremes of age, has underlying disease or comorbidities that may impair the healing process, such as, for example, diabetes mellitus and renal impairment. Any use of medication such as steroids, or if patient is on chemotherapy, obesity, any lack of nutrition, any impaired blood supply, and also any lifestyle that may lead to poor wound healing, which includes smoking and alcohol. And then As for the local wound assessment, we have to do a review of wound history on how the wound happened, uh, what causes the wound to occur, and then when, where, and who. And then next we assess the physical wound characteristic, which include location, size, base, and also depth of the wound. If there is any presence of pain, and then condition of the wound bed. Okay. Okay, local wound assessment include the principle of time, which T stands for tissue, I stands for infection or inflammation, M stands for moisture imbalance, and then E stands for epidermal margin.
Nanti gila.
As for tissue, we have to see if the wound is viable. So the evidence that the wound is viable is that if there is any evidence of granulation and epithelialization, which whereby the base of the wound will appear red or pink, and then if or we have to decide if the wound is non-viable, if it is necrotic or having slough tissue, and then if there is any signs and symptoms of infection, which include pus, pain, and mild odor, and then determine the moisture level, whether the exudate level is dry, minimal, or moderate or wet. And then check for the epidermal margin, whether there is epithelialization or advancing epidermal margin or non-advancing. And then in addition to time, we have to also have to determine the size of the wound, whereby we measure the wound surface area, which include length, width, and also depth. And then look at the surrounding skin too to assess for any signs of infection or ischemia or any maceration or crepitus. Yeah, so this is the example of a wound, which is a stage 3 pressure ulcer. So according to the time assessment, then for example, time. So we decide whether the tissue is viable or non-viable. So as we can see here, there is presence of non-viable tissue, black necrotic tissue, and then yellow slough tissue. There's also a presence of viable tissue, area of viable tissue, which is red in color, and also pink in color, which are granulation tissue and epithelial tissue, respectively. And then for eye infection, if there is any pus, pain, or malodor, so in this case, patient, it is a purulent with odor, so it has a infection sign. And then determine the exudate level, dry or wet. Then determine the epithelialization, whether there is a advancing epithelial margin, like in this picture. And then apart from that, we have to determine the site, which is on the sacral region, the size, which is the 12, uh, 12 in length, 8 cm in height, and then 1 cm in depth. Okay, and then after we have done with the wound assessment, then we document the wound accordingly to the size and also the time assessment. And also we determine the dressing solution and also dressing material that we use to dress the wound. Okay. And then patient can also come with infected wound, whereby patient can present with pus, pain, and also malodor. So the pathway for the wound infection include which will start with contamination, whereby there is presence of a microorganism. However, the microorganism do not apply or do not cause any clinical problem yet. And then it will advance to colonization, where there will be presence of multiplying microorganism. However, there is no host immunological reaction. And then proceed advance to the local infection, whereby there will be presence of inflammatory response and tissue injury due to the ability of the multiplying microorganism to invade viable surrounding tissues. And then finally to the systemic infection, whereby the microorganism will present in the bloodstream, causing systemic immune response. So if the wound is suspected to be infected, then we have to take sample of culture and sensitivity. So some indications for taking culture and sensitivity include wounds that have clinical signs and symptoms of infection, which include swelling, warm, erythema, pain, purulent discharge, discoloration of surrounding skin, wound breakdown, lymphangitis, and if patient present with fever. And then extensive burn wound, suspicious wound with implant, vascular graft, or skin graft rejection, and chronic non-healing. So as for the type of specimen that need to be collected is different depending on the type of the wound. For example, if for superficial wound, then we can take a wound swab we can sample wound swab, and then wound if the wound has a base, for example, ulcer wound, which has a deeper part of the base, then we can use tissue sampling for culture and sensitivity, and then fluid sampling for wound with cavity or sinus or pockets, and then an aerobic culture collection for wound with suspected anaerobic infection. Then we have to take aspirates or fluids. Okay. So wounds that are likely to contain anaerobic bacteria, whereby we have to take a spirit of fluid instead of swab, include wounds that are in close proximity to the mucosal areas, wounds that are deep and contains devitalized tissues such as necrotizing fasciitis or gas gangrene, and then chronic non-healing wounds with poor blood perfusion. Okay, that's all from me. Thank you.
Okay, overall it's okay. Just that when you are talking about classifications, you have to know the reason behind the uh, kind of classification being developed. In fact, it's not just in wound, in any classification. When you're talking about classification in medical punya field, usually there's a strong reason why that kind of classification been developed. So you understand what is actually reason behind the developments of all classification you presented just now. Then you see that your earlier statement is not that correct. Okay, your earlier statement that you said this is not that important with regards to classification, blah blah blah. Now that's not right. It's actually important in terms of what fundamentals behind the classification, because the classification been developed with reasons. Your contamination, for example, degree of contamination. That's purely from the study of a certain classification carries a certain percentage of infection developments. So that's why you go on, with regards to that, you go on prophylactic antibiotic or therapeutic antibiotic. Okay, that's one example. So classification is always important as a basis of management. Provided you understand lah what the reason behind all kind of classifications. Okay.
Okay, bro.
Okay, Assalamualaikum and good evening, everyone. So I'll continue the presentations on the concept of the wound care management. So I'll divide the wound care management into four, which are acute wound, chronic wound, non-healing ulcer, and so life-threatening wound management. So the first one is acute wound, which is the burn wound. So the burn injury is the surgical emergency. And the aim of management is to achieve early wound closure and to prevent burn sepsis. And it's important to do early tangential excision and also skin grafting in order to prevent the occurrence of the hypertrophic scarring and also disabling contractures, which is the complications of the wound. Okay, the causes of the burn include electricity, hot liquid, thermal, toxic inhalations, radiations, and also chemical. For the diagnosis of burn death, there are three: first degree, second degree, and also third degree. So for first degree, which is confined to the epidermal layer, so patient might come with the hyperemic wound with no presence of the blister, and the capillary refill time usually present less than 2 seconds. Patient might feel very painful over the affected area because in first degree burn, the nerve ending are fully exposed to the stimuli, as the epidermal covering the epidermal area is absent. So, and the spontaneous healing
Where from where you got you get this?
from CPG.
No, because first degree burn is an epidermal burn. Means that you lost your epidermal.
Mm.
It's not hyperemia. Hyperemia, you can actually develop, you can progress into first degree burn, which is epidermal burn, or you're going to have burn, no burn. If the epidermis does not lost, then hyperemia is not considered as burn. Remember, we are classifying the degree of burn in terms of per epidermal or dermal loss. So it's going to have a break in the of integument, then only you call it wound. Remember I told earlier on?
Oh yes. So I
So
suppose to say,
hyperemia is not first degree burn. Unless you develop blisters after that or lost the epidermis, then only you consider as first degree. That's why first degree burn is epidermal burn. Burn means damage lah. Okay.
okay, proceed.
In fact, hyperemia is not a color. It's a red, cherry red appearance.
Okay, Prof. Okay, whereas in partial thickness, second degree burn, there are superficial and deep dermal. So in superficial dermal, there will be pale pink burn. Okay, and whereas in the deep dermal, there will be presence of blotchy red. Um, Superficial dermal is usually present, however absent in deep dermal. And sensation, superficial dermal seem like first degree burn. Patient might feel very painful over the affected area. However, in deep dermal, there is usually absence of the sensation. And in the spontaneous healing, in superficial dermal, usually, yes, there is spontaneous healing. However, deep dermal, there is no spontaneous healing. Whereas in full thickness, third degree burn, for blister, capillary refill, sensation, and spontaneous healing wise,
It's not that accurate, yeah. Upper deep dermal, you know that this actually reticular dermal is still there. So by principle, it still can reepithelize. It's just that because it will take longer time. So when the wound exposed more than 1 week or 2 weeks, then you are talking about secondary infections. So which usually will damage the reticular dermis, remaining reticular dermis. So that's why it doesn't be considered as non-healing punya wound, no spontaneous healing. But by apa principle it still can heal, spontaneous healing. And spontaneous healing also it's not a good word. Okay, it's supposed to be healed by reepithelizations or healed by contraction. So full thickness burn also is actually heal. You can have a spontaneous healing by the means of a wound contraction. Okay, so spontaneous healing is not a good word to use there. So that's why I asked. There's a lot of things that is actually not accurate in this table. Your reference.
Yeesh.
Spontaneous healing means that it heal by you not doing anything, isn't it?
Yes, Prof.
Then, or full thickness also can heal. Just that heal by contraction.
Contraction, okay.
Uh, So that's why less than 1% full thickness burn, usually you still can treat conservatively.
Kesian bodoh. To be fair kan,
Okay, Prof.
kesian gila kat tim kita.
So all the degree of the
Ada
burn
pemenang
can
tiga, ada
heal,
pemenang tournament
but
legend
maybe
kan. Kata kau paling susah
one of
tu
another may
dekat
take
dalam
another
grouping diorang.
more
Bayangkan
time
macam mana
lah
kau
to
nak
heal.
menang. At least grouping sebelah sana
No,
ada
you only allow the
so far
spontaneous
kau
healing in terms of
Ada
reepithelizations.
Malaysia punya winner pasal adik
Okay?
England punya winner. Babi jahat
So
satu.
when you heal by contraction, you are talking about a fibrosis formation,
Grouping ni jahat gila.
which is going to be a very bad scar. So the better alternative is to get it
Langsung.
healed surgically.
Nak tahu tu jahat.
So that's why
Kalau
your statement there is actually confusing lah. So it should be healed by reepithelialization, which is actually can be allowed in first epidermal
Yes,
burn as well as the
superficial.
superficial burn or superficial dermal.
Mm. Okay.
Anyway, first degree we call it superficial burn. Okay.
Okay. Next. Okay, as for the management of the wound, okay, after immediate first aid, the principle of simultaneous resuscitation should be followed as per ATLS principle, which is the Advanced Trauma Life Support Principle. So we follow the ABCDEF flow, which the first one is airway, breathing, circulation, disability, exposure, and also fluid resuscitation. And then after that, we assess the burn areas, which we follow the Lunn and Boulder chart ataupun rule of 9. So which what I've read in children or infant, widely used. The Lunn and Boulder chart is widely used in infant and children because the ratio of the combined surface area of the head and also the neck of the children to the surface area of the limbs is typically larger in children. So there is difference of percentage lah. However, in adults, usually we use rule of 9. So kita kira patient's palm is equivalent to 1% of body surface area, which the entire head and neck is 9% of the body surface area. The entire right arm and the entire left arm 9% each, and also the entire right leg and entire left leg is 18% each. And for the groin area is 1%. Next. And then we start fluid resuscitation as per Parkland formula. It's only used or include in the partial and full thickness burn only, which the Parkland formula is 4 milliliter times by body weight in kg times by total body surface area equal to total fluid volume in the first 24 hours. So the half of the volume will be given in the first 8 hours, whereas the other half will be given over the next 16 hours. Okay. And then we follow the local protocol for tetanus and to give adequate pain relief to the patient if needed. And also in epidermal and superficial partial thickness burn, we have to continue with either topical antimicrobial dressing, SSD, or paraffin gauze until the wound heals. And if the burns are full thickness, which are likely to heal within 3 weeks, we have to refer patient to a specialist where patient may require tangential excision and also skin grafting. And also the prophylaxis of antibiotic is usually not needed unless there is evidence of infection. And also we have to spin the affected joint to prevent any contractures. And we have to allow patient for rehab upon discharge for fully functions of the joints. And we have to follow up the patient for at least 6 hours up to 1 year to detect any complications of the wound. And as for the indication for the referral to specialists, like I said before, there are three. When the first one is when there is no progressions of healing after 3 weeks of treatment. Secondly, when there is presence of the slough, necrotic patch or infection in the affected site. And thirdly, when there is occurrence of the hypertrophic scarring and early contractures, which indicate the complications of the wound.
What the fuck? Manga apa ni?
Next. Okay, second is the traumatic wound and the acute wound. So the aim of the management is to achieve wound healing in the quickest possible manner with minimal morbidity and also best cosmetic results. So as per history, we can ask patient the time elapsed since injury, the mechanism of injury, and also the cleanliness of the wound and any possibility of retained foreign body. And further history is we ask regarding the allergy, the medication, past history, the last meal, and also the environment. For the physical examination, inspection, we inspect the anatomical location and also the associated organ involved. And we inspect the size of the wound, the age, the tissue loss, the cleanliness, the viability of the tissues. And as for the palpation, we felt the crepitus, if any, and the foreign bodies, look for neurovascular status, and also for the movement, joint movement. And as for investigation, X-ray is indicated to rule out any foreign bodies, in the presence of foreign bodies, or if you suspect a patient to have bone fracture. Okay, for the principle of treatment, the first one is only one is we have to treat the limb, or we have to treat life or limb strengthening condition first, and then so we follow the ATLS principle, the ABCDF, airway breathing, circulation, disability, exposure, and also fluid resuscitation. Okay, for the adjuncts, antibiotic easily not needed except in the case of communication with bone fracture or joint space, in area with difficulty in adequate debridement, and when there is delayed treatment, which is more than 6 hours from the onset of the injury, when there is involvement into the hollow viscous organ, for example, like GIT, and in immunocompromised patient, and in clostridial prone wound, soil contamination wound. And so next is antitetanus, according to the local protocol, splinting, colostomy for certain perianal wound, and also lastly for continuous bladder drainage if indicated. Okay, for the management of traumatic wound, first we have to manage the bleeding wound in primary survey. So first we have to stop the bleeding rather than focus on the closure of the wound. So the things that we can do is direct pressure compression or hemostatic sutures, or we do arterial forceps, usually used in scalp wound ataupun major vessel injury. Okay, secondly is local or general anesthesia. So it depends upon the site and size of the wound, and also the allergic constraints, and depends on the patient factors, for example, like age and also patient's preference. And thirdly is toilet and debridement. So we have to do the thorough irrigations with normal saline to remove foreign material and dirt, and also to debride the unhealthy tissues. And lastly, for dressing,
No clue what
so
this
we
slide is
might
about.
use any dressing that is available, and the dressing must not stick to the wound and has some absorbent properties. And for dressing, it will be further explained by our next presenter. Okay. And for advice on discharge, we can advise patient to keep the wound dry, and shower is only allowed after 48 hours, but to avoid soaking wound. Advise patient on getting and not to avoid wound dirty, to avoid exposure to direct sunlight, to seek medical treatment if wound is having full swelling, when there is extreme pain or extensive discharge, and to give date for removal of sutures. Okay, next. Okay, next is a diabetic foot ulcer for chronic wound. So diabetic foot ulcer is a foot that exhibit any pathological that result directly from diabetic mellitus or any long-term or chronic complications of diabetic mellitus. So the pathophysiology of diabetic foot ulcer, there are three. It could be due to neuropathy, so neuropathy, macroangiopathy, or vascular disease, or immunopathy. So the clinical presentation, patient might come with soft tissue infection, confined to superficial to deep tissue infection, ataupun patient might come with osteomyelitis, septic arthritis, gangrene, chronic non-healing ulcer, and also or combinations of the stated condition lah.
Gambar kita tu, yang gambar yang kau tukar
Yeah.
ni tak banyak
Next.
beza dengan gambar original.
Okay, for the diabetic foot ulcer, there is a classification that is used, which is Wagner classification, which is up to grade 5. So for grade 0, there is no ulcer in the high risk foot. And for grade 1, there is superficial ulcer, which involve the partial or full skin thickness, but not the underlying tissues. In grade 2, there is deep ulcer. It penetrates down to the ligament and muscle, but no bone involvement and no abscess formation. However, in grade 3, there is also deep ulcer with cellulitis or abscess formation, often with osteomyelitis or joint sepsis. Grade 4, there will be presence of gangrene, and grade 5, there will be extensive gangrene involving the whole foot. So you can look at the pictures provided for the disease progression, so the diabetic foot ulcer. Okay, for the management of diabetic foot ulcer, the aim is to control the infection for the wound management and to prevent amputation, to maintain premorbid foot or lower extremity function, and to prevent recurrent ulcer. And for the general management, it's a multidisciplinary approach, which it's involving the dietitian, the pharmacists, the doctors, and also the wound care team lah. So also we have to maintain the good diabetic control in patient for systemic antibiotics, and to optimize other comorbid complications, and to advise patient to stop smoking. For local management, wound or ulcer management, it depends on the severity of the wound, the vascularity, and the presence of the infection. And for the debris infected or necrotic tissue, following the wound management, do not hesitate to perform debridement if indicated, and amputation may be the treatment of choice. We have to minimize the risk of reinfection, and if indicated, we establish adequate blood supply, and we have to offloading with contact casts, and to advise patient on good foot care and footwear. Next. Okay, next is venous ulcer. So venous ulcer is the commonest cause of the leg ulcer. It's due to the presence of venous hypertension in the lower limb. So there are two: ulcer secondary to primary varicose vein, and secondly, ulcer secondary to deep venous incompetence. So as for history, we have to rule out the risk factor, ask patient regarding the history of deep vein thrombosis atau varicose vein, and ask patient regarding the symptoms of chronic venous insufficiency. If patient might feel heaviness on the cuff after prolonged standing. Okay. For physical examination, we examine the ulcer or wound, and then we look for any varicose vein if present, and also to feel the peripheral arterial pulses. Next. Okay, for the management of venous ulcer, the most important components of treatment is to elevate the leg and also to apply the compression bandaging on the affected legs. So as for the elevations of the legs, we have to position the legs higher than the heart level, and also to apply compression stocking and compression bandages. So we can use 4 layer or 2 layers in acute phases. And in case of venous ulcer secondary to primary varicose vein, patient should be referred to surgical intervention with high saphenous vein ligations once the acute phase and infection is under control. So, and for pharmacotherapy, we can give patient venotonic agents ataupun hemorrhagic agents to help with the blood flow, to increase the blood flow in the arteries. And lastly, we can advise patient on lifestyle modification. Okay, for the 4-layer compression bandage too, we have 4 layer kan. So first layer, the material used is orthopedic wool. Second layer is cotton crepe bandage, followed by elastic extensible bandage. And lastly, the most outer layer is cohesive bandage. Okay, next. Okay, for the arterial ulcer, and next is arterial ulcer. So arterial ulcer are ischemic ulcer in patient with peripheral vascular disease. So it happens due to reduced blood supply to the affected limb, which cause delay or non-healing of the ulcer. So as for the management, you can see on the right side, the arterial ulcer can. So first we inspect the condition of the, we feel the condition of the peripheral pulses, and if it's normal, we can proceed with wound debridement and care. However, if the pulse is weak or absent, we look for ABSI. So if ABSI is normal or high, next we look for the toe pressure, either it's normal or not available or reduced. If it's normal, we can proceed with wound debridement and care. However, if the toe pressure is not available or reduced, we have to proceed with imaging. And if in imaging it's confirmed that a patient have weak pulses or no pulse at all, so we have to proceed with revascularization. Same also in weak or absence pulses. When we've done the ABSI, when it's reduced, so we proceed with imaging. And if it's confirmed no pulse, so kita proceed with revascularization. Okay, next. Okay, next is pressure ulcer. So pressure ulcer is a localized injury to the skin or underlying tissue, usually over a bony prominence as a result of pressure in combination with frictions. So for the prevention, so the prevention is the main modality in the management of pressure ulcer. So we have to know the proper bed positioning. So the proper bed positioning is the head end of the bed is prop up to not more than 30 degree. And we have to turn patient every 2 hours. And we have to check for the bony prominence once or twice a day, and to provide the appropriate type of mattress overlay or chair cushion to reduce pressure during sitting or lying. Okay, for the general treatment, we have to restore tissue perfusion by relief of pressure. We treat the underlying systemic problem. For example, if patient have anemia or hypoproteinemia or diabetes mellitus, we have to do or the in normal lah. And then treatment of reflex spasm, we could give patient baclofen or diazepam, and we have to prevent or treat the infection. We have to improve patient's general health and also nutrition. We optimize our function status, improving quality of life. We have to cooperate with other service as a whole, and then we have to prevent new ulcer development or recurrence. For local treatment, it could be conservative or surgical. Next. Okay, so these are the staging of the pressure ulcer. So the first stage is there is intact skin with non-blanchable redness of the localized area, usually over a bony prominence. Okay. In stage 2, there is partial thickness, loss of dermis, presenting as a shallow open ulcer with a red pink wound bed without slough. In stage 3, there is full thickness, tissue loss, and the subcutaneous fat may be visible, but bone, tendon, or muscle is not exposed. However, in stage 4, it's full thickness tissue with exposed full thickness tissue loss with exposed bone, tendon, and muscle. And for unstageable loss in which the
Mat
muscle is
takut.
covering by slough, and there is also the presence of some blood in the wound bed. And lastly is suspected deep tissue injury when there is purple or maroon localized area of discolored intact skin or blood-filled blister due to damage of underlying soft tissue from pressure or from pressure. So the area may be preceded by tissue that is painful, firm, mushy, boggy, warmer, and cold or cooler as compared to adjacent tissues. Okay, next.
Bukan, let's talk.
Okay, next is non-healing ulcer,
Like
the
gini
third
tak boleh
classification. So, non-healing ulcer is a wound that has no signs of healing process within 2 to 4 weeks after interventions by proper wound management team. So, the features of non-healing wound include the size remains the same as the onset of the injury, and secondly, there is persistent discharge. So, the investigation, we can do X-ray for suspected bone involvement, to do duplex for suspected vascular, biopsy for suspected malignancy,
Alamak,
or
tak
deep
besar
tissue
gila apa?
culture for
Jangan kau.
suspected
This is what my genetics
infections.
were used for.
Okay, the goal of management, the timely healing of wound with minimal morbidity and best cosmetic and functional outcome, and to prevent recurrence of the non-healing ulcer, and to improve the quality of life in patient. So the principle of management is also a multidisciplinary approach. So, and careful documentation of progress of the wound is needed, and we have to utilize appropriate adjuncts where applicable. We have to identify the cause if possible, and to treat the cause. We have to treat associated symptom. For example, if patient feel the pain, we can prescribe patient with analgesics. We consider lifestyle modification if patient is smoking ataupun patient ada morbid obesity. So we advise patient for better lifestyle lah. And then risk factor reduction to prevent recurrence. Okay, for the management of non-healing ulcer, first we have to do the toilet and debridement of unhealthy tissues or biofilm, surgically, hydrotherapy, or chemical, surgical. And for special wound may require special dressing. Okay, later will be presented by our next presenter. And then for dressing, the choice depends on local situation and resources. And dressing is targeted to the current wound condition. Okay. And the precaution, the arterial ulcer are systematic disease which need to be looked into, especially the cardiovascular state. And malignancy may be secondary to the chronic ulcer. And any contraindication is specific treatment. So we have to look for any contraindication before we prescribe patient with anything. For adjunct, antibiotics, analgesic, offloading, advise patient stop smoking, splinting, colostomy, continuous belly drainage, and hyperbaric chamber. Last is life-threatening wound. So life-threatening wound, or we call as necrotizing fasciitis, is a potentially fatal infection that is characterized by rapid progression with widespread necrosis of the subcutaneous tissue and superficial fascia. So the infection may also lead to gas production and sepsis. It is more likely to occur in immune compromised patients. So there are 3 subtypes. Subtype 1, polymicrobial. Type 2, from group A beta hemolytic streptococcal. And type 3, due to Clostridium perfringens, etc. Okay. So the flowchart management of life-threatening wound. So patient if you diagnosed with life-threatening infection, first we have to inspect patient systemically. We have to do systemic assessment, look for the vital signs, the signs of sepsis, tengok the hydrogenesis status and comorbid illness. And then we have to stabilize patient, treat and optimize comorbid illness, improve hydration and anemic level to correct the metabolic status, and also to start patient with intravenous antibiotics. And for local assessment on the infected site, we have to do extensive wound debridement and wound care to repeat the wound debridement and wound care. And if still no progressions of healing, amputation might be one of the treatment of choice. And then
I'm not fan. He's pasal.
I think that's all from me. Thank you.
Monster condom for my Magnum dog.
Assalamualaikum.
Oh,
So we
Allahu Akbar,
proceed
balik ketiga.
with wound care that comprise of wound cleansing, dressing, debridement, and brief on adjunctive treatment, and lastly is the algorithm. So first is wound cleansing. So the definition is a process to eliminate inflammatory contaminants which can impede or prevent healing and increase risk of infection from the wound surface. The contaminant include necrotic tissue, excess exudate, foreign bodies or object, and infected tissues. So for the wound cleansing, there are two solutions that we usually use, which is antiseptic solution and non-antiseptic solution. But we also have other alternative solution like povidone iodine, hydrogen peroxide, sodium hypochlorite, etc. But all these solutions are painful on application and can cause harm to tissues if used as dressing because they have cytotoxic properties. And however, a short-term use may be permissible. Okay, next. So we have two solution which is non-antiseptic, usually used for clean wound, and the commonly used solution is normal saline and water for irrigation. So for normal saline, it is preferred for most type of wound because it is physiologic and safe, and it is less effective. However, it is less effective in dirty and necrotic wound, and not advisable in MRSA and Pseudomonas infected wound. And other thing is that once we open it, it should be used within 24 hours. And second one is water for irrigation. This one is less physiologic compared to normal saline. However, it is still safe to be used and can be used in MRSA and Pseudomonas infected wound. As compared to normal saline, we don't use that for that kind of case. For antiseptic solution, it is used to clean dirty and infected wound, and the commonly used is chlorhexidine, superoxidized solution, and polyhexamethylene biguanide. However, the superoxidized solution and PHMB is usually costly, and we not use it frequently. We usually use chlorhexidine. So for this chlorhexidine, it is effective against gram-positive bacteria, fungi, and viruses. However, it is less effective against gram-negative bacteria, and it has both bactericidal and bacteriostatic action. And yeah, as I said, it is readily available in healthcare setting. Next. So next is wound dressing. So the principle of doing the wound dressing is we want to make sure that our wound have a moist wound healing environment, which is not too wet and not too dry. So when we are choosing the dressing material, we need to consider a dressing that can maintain the moist environment. So principally, if the wound is wet or highly exudative, we need to use dressing that can absorb the exudate. In contrast, if the wound is dry, we need to use dressing that can moisture up the wound. So the aim of to protect the wound from trauma and microbial contamination, to reduce pain, to maintain temperature, to absorb drainage, and debride wound, and to control and prevent hemorrhage, as well as to provide psychological comfort. So the characteristic of ideal or optimal dressing include to remove excess exudate, waterproof, to maintain moist wound healing environment, trauma protection, allow gases exchange is appropriate, non-adherent, and provide barrier to pathogen, safe and easy to use, as well as provide thermal insulation. So this wound dressing can be categorized into conventional and modern or advanced or active dressing. So for the conventional, we have gauze that is soaked with normal saline or antiseptic. And secondly is the gamgi as a secondary dressing. For the modern, we have variety of choices. Next.
I'm going to speak as slowly as I can.
So we have a variety of choices for the modern dressing. But as I said before, we need to make sure that we choose dressing according to the wound, and we want to have a moist wound healing environment. So usually, if dressing that can give a moist healing environment, usually is a gel like hydrogel or hydrocolloid. However, if a absorbent that dressing that have properties of can absorb the high oxidative wood, like foams or hydrofiber. So we will go briefly one each of these modern dressing. So first is the film. So it protect against contamination and friction. Also can maintain the moist surface. And it is also transparent, so we can facilitate assessment, that meaning that we can see the wound underneath it. However, the disadvantage is it can strip away the newly formed epithelium on removal of the dressing. Next is hydrogel. So this one can rehydrate, debride, and dislodge the wound, uh, as well as to promote moist healing. However, this hydrogel, it needs secondary dressing after we apply the gel. The third one is hydrocolloid. This one also provide moist environment and absorb exudate. So, however, it has unpleasant odor and it is difficult to use in cavities. Next is we have calcium arginate. It also can absorb wound, exudate, and maintain moisture. However, it is not very helpful for dry wound. So if we have dry wound, we cannot use this one. Next. Next we have foam. So this one is absorbent and cushioning. So it can design for cavity wound and highly absorbent for a highly exudative wound. And however, it can adhere to wound if the exudate dries out. Next, we have hydrofiber. It can use for managing heavy exudating wounds, and it can maintain moist healing environment at the same time. However, it not helpful for dry wound, and also need secondary dressing after this dressing. Next is charcoal. It is special because it has odor absorbent. We use usually to reduce the odor. However, this one also needs secondary dressing. So this charcoal we can do is as crush or powder, where we can put it on the wound. Next, silver, which is to reduce bacterial bioburden in infected wound. However, this one is not used frequently, because some silver dressing can discolor the wound. And next we have other dressing like multifunction dressing, composite dressing, and other advanced dressing. Next. That we have also I have paraffin dressing that we always encounter in ward, which is Petitgrass. And these two also is a collagen dressing, which is under advanced dressing, advanced dressing. Next. Third is wound debridement. So the definition is a process to remove non-viable tissue and contaminants from the wound to promote healing. So we have several methods of debridement like surgical, autolytic, enzymatic, mechanical, biological, and hydrostatic. So how to know whether the wound is viable or not is by looking at the tissue. For example, the fat tissue, if it's non-viable, is will look dull, grey, or brown to black. However, if it is viable, it will look shiny yellow. For the fascia, similar, it will look dull, grey, brown to black if it is non-viable. If it's viable, it will
Oh,
look
mantap.
glistening white. And then muscle, for non-viable, it will look dark red, brown to grey. If it is viable, it will look red like a meat. And it is possible. There is possible contraction if pinch the muscle. And all tissues, if it's non-viable, maybe no sensation, not bleeding, and have foul smelling. If it is viable, it has good vascularity with no or little odor. Next. So first is surgical debridement. Before,
Tak ada.
uh,
Habis dah.
okay, for surgical debridement, the definition is to remove necrotic tissue by sharp debridement using scalpel, scissors, and etc., which is to cut necrotic tissue from a wound as to prepare the wound bed for optimum healing. So indicated in extensive devitalized tissue or a wound that has sign of advancing soft tissue infection or sepsis, or with wound with thick adherent eschar or callus formation. So before we do the surgical debridement, we have a few things to assess to make sure that this wound is indicated for surgical debridement. For example, the nature of the necrotic or ischemic tissue, and we need to choose the best debridement procedure to follow. We need to know the risk of spreading infection with and the use of antibiotics, and the presence of underlying medical condition causing the wound, the extent of ischemia in the wound tissues, the location of the wound in the body, and the type of analgesia to use during the procedure as well as after the procedure, and possible complication. Next. This is the basic principles of the surgical debridement, where we debride the tissue in stages to minimize damage to the healthy tissue, and we need to stay within the given fascia plan during the debridement to avoid the spreading of the bacteria into the lower layers. And if a fascia plan is reached, we need to stop and reassess the situation and to determine whether we need a deeper debridement or not, because a deeper debridement meaning a higher risk for infection and higher risk for damaging the surrounding tissue. For the small bleeders can be stopped with the application of the pressure, while a large bleed can require diathermy or ligation of the vessels. And pain control during debridement may be needed and achieved using oral or topical analgesic or IM or IV drugs, original or GA. Next. Next, we have autolytic debridement, which is defined as a process by which the wound bed utilize phagocytes and proteolytic enzyme to remove the non-viable tissues. So this process can be promoted and enhanced by maintaining a moist wound environment. So the mode of action is by using the hydrogel, where it will gently rehydrate the dry necrotic tissue, provide moist wound healing environment, and soften the necrotic tissues. The third is the enzymatic debridement, which is, as definition, is to stimulate the breakdown of the non-viable tissue. And this enzymatic is faster compared to autolytic because it is a body response. So the example that we can use to help for this enzymatic debridement include Clostridium peptidase A, as per a picture, and honey and other materials. Next is mechanical debridement, which is definition is to remove the unhealthy tissue or non-viable tissue with a moving force or mechanical force. So we have a few um, mechanism like wet to dry gauze, where we apply the wet gauze to the wound, and after it dries and stick to the wound, we physically remove the gauze, which when we remove it will take the dead tissue along with the gauze. However, this peeling of this necrotic tissue can be very painful to the patient. Next is scrubbing, where we remove the biofilm and debris using the blunt edge of the scalpel or forceps. Next is whirlpool or hydrotherapy. This one we use a low water pressure force to cleanse and debride the wound, like in the picture. And this one is less harmful to normal cells. And lastly is wound irrigation, where we irrigate and debride the wound using the non-antiseptic cleansing solution as like normal saline or water for irrigation. Next is biological debridement. It is the use of sterile maggots for wound debridement in humans. This therapy is hypoallergenic, non-invasive, and effective. This one also known as maggot debridement therapy, MDT. So the two species that usually used for this is Lucilia rucoprina and Lucilia sericata. So the mechanism of this debridement is to remove slough by the protease, which is the enzyme that produce or synthesized by the maggots to dissolve the necrotic and infective material, and then it will stimulate wound healing by promoting granulation and epithelialization, and that maggot will also disinfect the wound by ingesting the bacteria, causing the pH changes for a good pH for wound healing, and also have antibacterial substance. However, it is contraindicated for wound that need urgent debridement, bleeding wound, poor vascularity, or wound with abscess, or patient generally have entomophobia, which is fear to insects. Patient have fistula, joints, or deep cavities, or a wound that is near to neurovascular bundles. Next, lastly is the hydrostatic debridement, where we use the high power hydrostatic debrider as in picture. So this instrument, it can excise tissues with a stream of saline, where it can vacuum and remove the tissues simultaneously. So this hydrostatic debrider will hold, cut, and remove the tissue at the same time, and this one is more precise and more selective than scalpel. And it enables surgeon to precisely target and remove the devitalized tissue and contaminate, at the same time preserve the collateral healthy tissue. Okay, next one is the adjunctive treatment. We have honey, we have hyperbaric oxygen therapy, and negative pressure wound therapy. So first one is honey. So the function is to promote granulation and epithelialization of a wound for secondary intention healing, which also can be followed by further surgical procedure for soft tissue coverage like split skin graft or full thickness skin graft or flaps. So for honey dressing, we use therapeutic honey, which is prepared specifically for medical use, and they undergo sterilization through irradiation process. However, that one and that do not damage their constituents. They have few benefits like antimicrobial property, promote enzymatic debridement, deodorize mild odorous wound, and so on. However, it is contraindicated in patients who have history of allergy and sensitive to bee sting or honey products, or it is contraindicated in a dry or necrotic wound because honey can dries up the wound further. Next is hyperbaric oxygen therapy. So this one is we use intermittent 100% oxygen, which is greater than surrounding pressure or ambient pressure, where the oxygen will act as a drug, and we use hyperbaric chamber as a dosing device. So the main the main purpose is to elevate tissue oxygen tension to give a primary effect. So some conditions that can be used include diabetic foot ulcer,
Oh.
necrotizing
Lompat
fasciitis,
dulu.
chronic
Ya,
osteomyelitis, and
mantap.
trauma burns. So for the mechanism of action, it will stimulate
First one. Wait,
angiogenesis
what?
in ischemic tissues. It also can act as both bacteriostatic and bactericidal action and inhibit the gangrene bacteria like Clostridium perfringens and alpha toxin synthesis. Also, it can cause vasoconstriction and enhance collagen synthesis as well as leukocyte oxidative killing.
Mana arkon?
Third one is negative wound pressure therapy. This technique is to facilitate wound treatment by utilizing a subatmospheric pressure, where it will consist of placing an open cell wound interface like gauze directly into the wound surface, and we cover it with a occlusive film like in the picture. And after that, the negative pressure, which is below the surrounding pressure, is applied to the entire wound surface so that the wound will directly interface with the pump, and it can
Bukan. Aku tengah record dengan kau
the occlusive pump film will directly touch the wound surface. So it is indicated for huge, clean, or an exudative wound while waiting for the definitive wound closure, or for fixation of skin graft or tissue flaps. However, it is contraindicated in patients with clotting disorder, necrotic wound bed, because this technique can prevent the tissue growth, which is good for healing. Or it is also contraindicated in untreated infection or neoplastic tissue wound area. Next. Okay, this is how the NPWT work. You can read later. However, generally it help encourage granulation tissue at the wound site and help to reduce contamination from outside bacteria and also reduce cell death caused by dehydration. Okay, lastly is algorithm. So as per presented before, we need to assess the wound. If patient presented with wound, so we assess systematically and locally. For the locally, we will use the time flow, tissue infection or inflammation, moisture, and epithelial margin. So based on this, it will categorize the wound into 8 categories, and each categories of this wound have different management and dressing material that can be used. So principally, first is necrotic tissue. So we want to know whether the wound have slough or not, necrotic or not. So generally, if wound that has slough, we will need to debride the wound. Next is infection. So we want to know whether the wound is infected or not, because we want to know whether this wound need for the antibiotics or not. So usually for non-infected, we do not need for antibiotic. However, for infected, must have antibiotics. And the third is we want to know whether it is a dry or wet wound. Because a dry wound, we will need to use a different dressing, and for a moist wound, we will need to use a different dressing. Okay, so based on all this, it will give 8 different categories of wound. We will go one by one. So next. So for the first wound, it is clean, healthy, granulating wound. So for this wound, it is all types of dressing can be used except for all those advanced one like silver, charcoal, and those things. And no use for antibiotic. And this one usually ready for secondary wound dressing, wound closure, and no need for debridement and so on. Next, the second category is clean and wet wound. So as I mentioned, it is wet wound, so we need to use a dressing that can absorb the exudate like foam, alginate, hydrofiber. So for the use of antibiotic may or may not based on underlying causes. For this one, we need to find the underlying causes and treat the underlying causes necessarily, if necessary. Third categories is dry infected wound with slough. So it is dry, so we need use dressing that can moisture the environment, and it is infected. Of course, it need antibacterial, and then slough. Even it is less than 35%. However, debridement is recommended or needed. Next. The fourth wound is wet infected wound with slough. So if it is wet, we need to use dressing that can absorb the exudate like foam, hydrofiber, and of course infected we need there is need to use the antibiotics, and since it is with slough, so debridement is needed. For the fifth category, it is dry, non-infected with slough. So dry need to moisten up the wound, need to use hydrojet or hydrocolloid. Non-infected, of course, no need for antibacteria, and it is have slough. Of course, debridement is strongly recommended. Next is the wet non-infected wound with more than 35% slough or necrotic tissue. So similar, if wet, we need use foam or hydrofiber. Non-infected may or may not use. We need to know the underlying of the case. And then surgical debridement is recommended. Next. For the seventh type, it is dry infected wound with slough. Okay, similar, need to use hydrojet or hydrocolloid, need for antibiotics, and need for surgical debridement. Lastly is wet infected with slough. So this one, we use hydrofiber or foam, need for antibiotic, and need for surgical debridement. I think that is all from us. Hello.
Yeah, okay. So mainly on the principle lah. So in medical, when you are actually having some principle, so always ask yourself why. You tak boleh accept macam tu je. Okay, thank you.
Prof, ada satu lagi presentation, Prof.
Dah lah.
Uh, benign and malignant skin lesion.
That one a big topic. Next, find another date.
Okay. Thank you, Prof.
Right.
Thank you, Prof.
Off.
Okay.